Good morning. On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Keys to Investigation, Change Management. Keys to Investigation, Process Mapping, Timelines, and Interviewing. My name is Kathy Reynolds, and I'll be one of your moderators for the program, as well as one of the speakers. Now I'd like to introduce yourself. My colleague Molly Quisenberry and I are both patient safety advisors with the Patient Safety Authority. We both interact with patient safety officers and other various healthcare staffs to identify safety hazards, risks, and reduce patient harm. Molly covers facilities in the North Central region, and I cover facilities in the Southeast region. Also joining us today is Kelly Gibson. She's a program manager with the PSA. In this role, Kelly has been involved with initiatives to decrease patient harm, such as education, webinar development, consultation, on-site observations, article development, and incorporation of the patient voice into PSA's work. So with that, we are going to talk today or continue our conversation that Patient Safety Authority launched last in the summer earlier this year to provide with our mission to continue providing education for development for healthcare professionals, but this project focusing on investigation and the steps and the tools that you can add to your tool belt to continue building your own capacity in the process of investigating adverse events. Overall, this Keystone project or Keys to Investigation is a series of educational opportunities, including monthly webinars, of which you're participating in one today. You can see in slide 2 the list of webinars that have already occurred on the left-hand top list there. And if you missed any of those webinars and you would like to catch up on the recording, you can reach out to your patient safety advisor and they will be able to provide that to you, the links to those, a list of the links to the recordings of the webinars that have already occurred. Today, we're talking about process mapping, timelining, and interviewing, and you can see the upcoming webinars still listed. And in the spring, excitedly, we'll be having more information to come, but some in-person workshops to get a little bit more hands-on with all of these topics, these tools that are components of the investigative process. So again, if you're more information will be coming out, but as you're interested, don't ever hesitate to reach out to your advisor, because those would be opportunities to do a bit more hands-on in an in-person setting. So with that, we thank you for being here. So today, again, we're going to be kind of talking, high level about what process mapping is, what creating a timeline for your event is, and interviewing, talking about some of the tips and hints that can help and where you get started. Also describing key characteristics and identifying those key components. So what is process mapping? Feel free to use the chat box. If I would be interested to see what people say. Just chime in. Do you routinely use process maps? Is it something that you are here to learn but haven't had a lot of experience with? Is it something that is very routine and embedded in your process and you're very comfortable with them? I'd be happy to see where people are. And I say that because this education is really geared to anybody in these roles that might be involved in the process in some way of investigation, but some people may be very new in that role and are learning these skills and are here to kind of build their own capacity, and others who have been doing this for a long time and are always looking to hear new conversation, build in their skills. So we have a range of folks that are here. If there's at any point you hear some concepts and you want to dig a little bit in further, that would be an ideal opportunity to reach out to your patient safety advisor, someone that you can have a one-on-one conversation with that can help you talk about, what does this process look like in our facility, and how, might I improve it? What resources do we have to build on, kind of meet you where you are. So, we all started somewhere, and I know that process maps used to seem quite overwhelming to me. Okay, what's a process map? How do I do it? And if you kind of Google it, you might see very complicated, engineering focused, very high level process improvement process maps. And it may look like something like, like this just seems out of my wheelhouse. Well, it's not. Let's, take it down and break it down to its simplest part. Process maps are an amazing tool for us to, and I always say in anything that we're doing, especially in improving or learning about something, as much as we can make the invisible visible, meaning making something a visual process as opposed to, trying to read on paper. Anytime we can make something visual and we can see relationship between things, that is going to impact our process positively and be a value add for us. So a process map at its most simplest form, it shows us, sequential of actions within a task and how they're performed sequentially to deliver a goal. It's a sequential visual representation of a process. And everything is a process. How you got here this morning is a process, whether that's driving to work and getting to your office, whether you work at home, whatever that situation may be. So when you think about process mapping, grab your whiteboard, get your wall, your Post-its. It can be very simple. So when would we map a process? When would we use this process? I also should back up and state we're talking about these three components of investigation and are not necessarily, even though we're kind of talking through them in sort of a process map and a timeline and then interviewing, it seemed like they are some sort of, set in stone order. I want to be clear that in investigation, it is, expect that process to be iterative. So as you go through investigation, at any point, you're going to learn more information and may go back and revise things. So you develop a process map and then you start talking to folks and doing interviews, you learn more information, then you go back to your process map and revise. So just keep that in mind, that investigation inherently is iterative. You learn more information, you go back and you add things to some of these tools. So feel free, as I'm talking, think about some reasons and put them in the chat box. So what are the advantages, or why is it good to use a process map? But when would they be useful? They help us to understand how a process works. Again, being able to step back, look at not only the steps, but also the relationship between those steps, the roles between people, decision points. They might be useful in a process improvement study. So we're talking about in the context of investigation, but you, again, proactively, FMEAs, failure mode effects analysis, where you're looking at a process, it's not really in reaction to an event, but you're proactively looking at a process to see where the failure modes may be. Or generally a quality improvement project, mapping out the process to see where are opportunities. Communication, that visual representation can communicate much better than a 4-page policy or a protocol on paper. Showing opportunities for better, needing to improve communication between individuals. It also can communicate that, again, with being visual as opposed to a process. Many times, if you do have some like a protocol on paper, you may see embedded in that a visual algorithm or a map to show how this process works. It's a good way to document a process and also can be very useful in project planning. So, like I was saying, the advantages, they're easy to learn and create. Again, they do not have to be complicated. As your skills build, I bet yours may be, your process maps may become a bit more involved, and that's great. But they don't have to be. Let me say allow staff to visualize the rows. Yeah. Oh, and identify decision points. That's what wanted to mention. Identifying those decision points, because when we can step back and look and see where are people making decisions, where might there be high risk, where are there opportunities for safety tools to be employed. So like everything, there are steps. We're going to talk about each one of these steps, so I'll just kind of list them now, but you want to define the process like anything before you launch it into the work. You want to define, what are we doing? Just like when you start a committee, you have a charter. What are we trying to accomplish? Who's going to be involved? So again, determining everyone involved, who are the right people to be there? Who has real knowledge of how this process actually works? Not what's supposed to happen, but what actually happens. Defer to that expertise, leverage the frontline folks that you have that have representation that can say, no, this is how it's really accomplished. Brainstorm those steps. Okay, it's not necessarily going to be in the right order at first, but you're just going to be gathering. And then as you construct the flow chart, you're going to organize things. You're going to start drawing relationships using arrows and test the processes in whatever way you do that. But like looking and saying, okay, did we miss anything? Is this what's really happening? What are we missing here? When we're defining the process, again, you want to start with a goal in mind. Like, what are we trying to accomplish? What are we trying to learn? The process is a sequential set of tasks, but there's different types of tasks. There's sometimes the You know, we can have in our mind the ideal task. Like I would say, like, what does it look like on paper? What does the policy say? This is what's supposed to happen. There's often what people think is happening, like their assumptions of what is happening. What you want to do with your process map is map the process that's actually happening. And some ways that you may have to, do that is getting input from the folks, but also observing like what's actually happening here, not just what's supposed to happen, because this is how you'll be able to identify those workarounds. Like if healthcare workers are great with identifying solutions to barriers, and we create workarounds, and some of them identifying those workarounds can say, oh, here's a failure or breakdown or a weakness in the system. Let's fix the underlying problem and then perhaps eliminate this workaround. But we wouldn't have known that if we didn't really understand how people are actually getting the work done. So you might start with something simple like a flow chart. Sometimes these terms I hear used interchangeably, flow chart, process map. I think of a flow chart as a very early understanding of the steps, the sort of high level, big sequential steps in whatever task you're looking at. So start laying them out. And then as you start to do that, more questions will start to arise and you'll be able to build on this map. So, let's think about something simple. How did, I mentioned this earlier, how did you get to work this morning? Let's assume for those of us that are in office that had to commute this morning, how did that happen? What were the steps? What were the steps in the process for you going from home to office, to your computer station where you are today? And it might look like something like this, the process of getting to work on time, right? I'm gonna wake up, get dressed, start the car, drive the car, park the car, walk into work, right? So this gives us an early sort of, or a high level understanding of the big steps that took you to get there. It's an everyday example of what we would call like high level mapping, but it lends questions, right? If we want to get more detailed, we might say, well, what are the steps to, like, what, I didn't just wake up out of nowhere. What happened for me to wake up? I didn't just miraculously become dressed. What were the sub processes, which is the word that we want to highlight here, the sub processes for each of these steps. So as you're doing, your process maps, think about those. You have the high level sequential steps in the task, and then what are the sub processes of each of these? And that may look a little something like this. You go to wake up. Are you a snooze button person? I certainly am. Hit the snooze button. Again, hit the snooze button. Like what, someone might say, wake up, my alarm goes off and I get up. But what really happens, as I was stressing before. So you're kind of hitting the snooze button a few times. Get coffee, get a shower, find clean clothes. But you get the point that each one of these steps, as you're doing like an investigative process, there's going to be sub processes and you want to start mapping them out. Now, as you start doing this, it's going to, it might seem like it's getting a little overwhelming. What are we looking at here? So this is all under part of defining your process, perhaps based on whatever the reason that you're doing this process map for, such as response to an event. There may be one part of the high level process that you really need to dig into, and then focusing your process map, say, hey, we're going to narrow the scope of this process map. We're going to narrow it down a little bit, and we're going to focus on the nitty gritty of the wake up or the walk into work part. I'm just using examples. But if you can imagine, let's use a healthcare example. If your task was, oh, we had an event. I want, someone says, map how labs are handled in the health system. Well, I'm going to have a lot of questions of what that means, right? So does that mean in the whole health system? Does that mean, how fruitful would it be if we were to just embark on this chaotic, how are labs handled? So narrowing it down, am I looking at maybe one campus? Am I looking at the process of specimen sampling at the unit, drawing the nurse drawing the blood until it's labeled and sent to the lab? Am I looking more at like once it gets to the bench and then how it's resulted? So all of that is the part of defining your process map and narrowing it down. And I think with that, I am going to pass to my colleague Kelly, who's going to pick it up from here.
Thank you, Kathy. So step 2 with this process is really determining everyone involved. And I think in patient safety, when we do almost any sort of work, we are looking at or working with multidisciplinary teams. So definitely consider your scope as far as who needs to be at the table, who needs to provide input, because we want to get the experts on whatever topic this is. Kathy was talking about getting to work on time. I knew somebody who kind of let's go back to COVID time in that era, and that individual had an employee who was not getting to work on time. Kind of had a conversation. Oh, I'll try better. Had another conversation because it was still continuing to happen, still running late. Oh, well, it's because I got to drop my kids off at daycare. Continued to have issues with getting there late. And when they really sat down and looked at and talked and discussed through what was going on, found out that with COVID, they weren't allowed to take their kids in. They had to do the drop off line. It literally was an employee coming out to get the kid, taking that kid back in, come back out, get the next kid in line, move up in line. Okay, well, what about, is there any opportunity to get there earlier? What about, well, no, they only open at such and such time. Even if I get there, I've tried to get there before they even open. The line's already, I'm 20 deep. So till we get through the line, this process was taking an extended period of time. So I just share that as a way to really be open-minded to other influential kind of components, and really getting to, if you don't talk to that individual, you're not going to understand the whole process, and maybe what are some of the barriers when you really start to look at the event that occurred that you're investigating. So really being open to those that are understanding the process, those that are involved. We have an OR team shown here in this slide, and of course, I think we all know ORs are complicated areas. There's a lot of high risk things going on. So you have teams of nursing, physicians, anesthesia technicians. You might even have reps coming in that are involved, and how and what is going on in the interaction between them. You might need a lot of input from other departments, roles of all those individuals, because we're going to be examining those relationships and how everybody is working together. Once you have all the right people at the table, so to speak, then it's kind of brainstorming those steps. Hey, is it that getting to work on time, it involves dropping kids off at the daycare? Oh, well, wait a minute. How many people are in your house trying to get ready at the same time? How does that kind of get into the mix, and trying to get to the bathroom? Yeah, we only have one bathroom here versus, you know what, we have 3 bathrooms, those kinds of things. So brainstorming all of that and just getting it out there, writing it down, however is the best process for you to get them in there. And it's not necessarily sequential at this point. We'll kind of move into that with the next step, but determining who's, and start looking at who's doing what during that process, and all those details. The amount of detail that you get into might be dependent upon what is the event that you're investigating, who's involved with that, how many people, what time frame is it kind of spanning. So some of that detail might be dependent upon each, and look different depending on each scenario. When it comes to constructing the flow sheet, and you've seen a couple, or the flow chart, you've seen a couple kind of sample scenarios. These are all possibilities, and similar to what Kathy said, you might actually, if you Google this, you can find all kinds. There's even more shapes and fun things that you can incorporate. If you are new to this process, you might only want to focus on maybe, say, the first 2 or 3 lines that are shown here. Don't get bogged down in some of this detail if you're new to it, versus if you are an expert on it, you might be able to help somebody who's new to this process using these philosophies. So the first box there is a process step. You're definitely going to be including those. The arrows are going to give direction to, as the process moves along, how it flows through the flow chart. With the kind of the sideways diamond, showing and indicating a decision point. So this is kind of a question where typically you have a yes, no sort of answer, and there's usually 2 directions out of that process or that decision point. So those are the ones that I think if you are new to this, you're going to really want to try to look at those and use those. Kathy mentioned something, I think she talked about whiteboards and whatnot. So here, once you get all these steps and you have them all thrown out, let's start to try to organize them to some extent. I know a lot of things that we do in patient safety, we're using Post-it notes to kind of put things out there. You can rearrange them, and as you find out more details or clarify the steps and how they occur sequentially, you can just move things around easily. I know I've tried in the past an electronic whiteboard, and I thought, oh, this would be great. I can draw on it. I can import it into an electronic document, and I'll have it as reference. And so I don't really necessarily have to copy and paste and take anything from my meetings. But I found that actually more cumbersome. So I kind of reverted back to just using Post-its, using flip charts. I can put Post-its on them, and then I can just tear the Post-it down. So whatever works best for you, whatever your resources are in your facility, that it's okay. You don't kind of pigeonhole yourself into using one sort of thing. We're going to start to look at, as we organize these, who performs what task, what departments are involved, which tasks are done concurrently versus which are more sequential. Do they cross over and kind of blend into one another? Are multiple people performing the same task? When you're doing this, just as you're writing individual tasks, make sure you're including a verb. You ideally want to have these actionable, that you can kind of see it, somebody is doing something. So this is an example of what it might look like for an outpatient outpatient having a CT exam. So they come in, and as Kathy talked about, defining that start point, or what is it where you're going to start, like patient arrives to the CT room, and where are you going to end at? How's that going to stop? What's nice about this one is that it kind of differentiates between, and you can see the legend in the bottom left, the CT technician and the radiologist. So at a quick glance, you can look at this and kind of say, oh, okay, I know, if I'm working in CT, I can figure out where the areas I need to focus on, versus if I'm one of the radiologists and I look at this, I can see here's where our role coordinates. But also around that, what other areas do you interact with? So this is an example of the visual representation. Again, yours might look even more complex depending on how detailed you're going to get with the map. We're going to talk a little bit about swim charts. Again, this is just kind of a swim lanes look at the same thing, but it's a visual representation where you're piecing it out, basically who in the organization is responsible for what process step. So as you lay out the process, what role is responsible for what piece, and then you can kind of keep their responsibilities, their steps in the process all together. So you're going to start in the upper left, you're going to kind of flow it out, you're going to keep, and if there is a step that involves multiple players, you're going to have to include that step in multiple lanes. So again, this is to arrange steps sequentially, kind of targeting the individuals that are performing. It's to help kind of look at the bottlenecks and remove redundancies that are in your process and really bring them to life. So let's look at an example. This is an outpatient office, I guess you could say, prescribing a prescription for a patient. And you can see it starts in the top left. The process is defined up top. You have the individual team players that are involved along, kind of listed down the side there, from the patient, the provider, administrative staff, pharmacy. Depending on how complex your process is, you could have a lot more of these, but you could also, depending on the process, you might have fewer, and it might not lend itself to doing a swim lane. I think about medication administration, you might have just the time, if you define your process from the time you get the medication from pharmacy, or you go and grab the medication, to actually patient administration, you're not going to have a whole lot of lanes. It might just be the nurse involved. So is the swim lane appropriate? Versus if you're looking at from when do you obtain the order the whole way to administration, that medication order goes through a lot of different processes. There's a lot of back and forth between team players. So yours would be more complex, and maybe it's more appropriate to use in those situations. So if we look back to this one, You can see the patient sees the provider is evaluating the patient. Do they need the prescription or not? So there's your decision point and kind of going from there. But when you look back at it after you've put this whole process together, you can kind of hone in on who's responsible for what. And you can, and I know Kathy said she had a pretty good example with this. I don't know if you want to chime in, Kathy.
Yeah, I'm sorry. I didn't want to interrupt you, but I was waiting. I just wanted to share like a real life example, a real story that I in a past role coaching a team that wanted to decrease SSIs out of basically focus on like the orthopedic service, SSIs out of that process. We used a swim lane diagram in the very beginning. I kind of interacted with all the different parts. And what was different was we weren't just focusing on the OR, the peri-op staff, with the pre-op, the peri, and the post and the PACU staff. We started this process, and on that left column was the orthopedic clinic, the pre-admission testing, pre-op, peri-op, post-op, the floor, the clinic, like all of the teams involved. So we looked at the whole process that the patient flows through. And it was very enlightening, and it really highlighted where there were missed opportunities to communicate things between the outpatient side and the inpatient side. So just to share that, it was very fruitful to really show the relationship, bottlenecks, opportunities, inefficiencies in a interrelated process. Again, like the patient's the most consistent, the one consistent part of a process, but we have all of these different departments, and that's often where we see breakdowns in communication and outcomes not as we desire. So thank you.
Thanks, Kathy. And I know I was thinking as another example, I know a facility looking at transitions of care and talking about patients who are admitted from the emergency department into the inpatient unit and talking about that handoff communication and some of that stuff, like whose roles and responsibilities. And you talk about that phone call, you would have a lot of input. You would have to make sure that you also include. So that conversation for handoff is one point in the process. But if you use a swim lane sort of like this, you would have to make sure that you would have to include that step in the process. You'd have to include that in the inpatient nurse as well as the emergency department nurse. So you just have to be aware of that one step might be listed several times with this process. So you've brainstormed, you have all the steps thought through, and it's time to start to kind of organize things. And we're going to start to draw the arrows up as far as kind of connecting the activities, linking one step to the next. So showing the flow sequentially through so that it's easy to follow. You're going to also, like as I mentioned with the swim lane, making sure that we have, if it is involving two individuals or maybe even more than two individuals, making sure that you're incorporating that same one task in multiple swim lanes. So this is about connecting, making sure the flow works through the process. Once you develop that, it's always good to test. Have somebody from the outside the event. Maybe it's somebody that's totally not involved. If it's an OR case, maybe it's somebody from outside the OR who's not embedded in that environment, because somebody like that might actually have more questions or more clarification opportunities, but you want to make sure you're not missing any steps or something is incorrect through your flow. So this is just about validating what you have developed and the process map that you have created. And you might need to revise it. You might need to maybe add something, change something, depending on what you find. So we're going to step into timelines. And while these are not very, I'll say just not very complex, I think professionally, these are one of the tools that I probably use the most in patient safety, just because no matter what the case was, how big or small the event was, the outcome, it didn't matter. I typically would start as I was looking in the charts and reading the event report. I would, without even knowing it, start to create a timeline. So a timeline is about looking at the date and times of key moments within that event and even leading up to that event after the fact. So there it's a living document. It's breathing. As you find out more details, you might add. You can include when you talk about factual statements. It might even be quotes from staff members, dates and times. Is whatever precision that you can add to it, and however in depth you can get to is very helpful and will help you in the end. In this day and age, we have so much technology that you can have timestamps for I'll say everything. As much in detail as you want, you can probably get it. It just takes time and being able to mine that get that information from whether it be IT or department specific, the actual departments. I worked with a facility that had an event where a patient came in, the ED, mental status change. The patient was not, a point of care glucose was not obtained. The patient ended up going to CT, I think by return from CT. I think the patient arrested, was totally unresponsive. It's interesting, the conclusions and speculations that were made early on versus by the time all this information and these timestamps were obtained, what we actually found in that event. Initially, it was kind of like, oh, well, the family came in and said they did a glucose at home and the patient's blood sugar was fine. Oh, well, the nurse probably didn't get the blood sugar and just went on what the family said and listened to them. And because it was a potential stroke, hurried up, went to CT. But as we started to peel back the layers of the onion, as we started to get details, and what we found, well, guess what? They did attempt to do a glucose, but the glucometer wasn't working. Oh, I bet why wouldn't a glucometer work? Well, the patient, we probably didn't do the QC. So the glucometer was like locked out. Well, actually, the lab got involved and they had where they had done the QC and they were able to run and find that detail. So, okay, we fill that in on our timeline, right? Well, guess what? The ED has a process that they actually do. Who is assigned to doing those checks and how often. They actually have a sheet where they sign off because we assumed, it just wasn't done. But here it's documented that the person did it. Oh, well, son of a gun. But, we got the stuff from the lab that said it actually was done. So we had that timestamp as well. And as we were just moving through the process, in the end, what we found out was they had actually, because then we assumed it was never docked and the glucometer, blah, blah, blah. What we found was that we were ready to put processes in place and fix what we thought was wrong. But when we talked to everybody, got all the information, all these timestamps, what we found was it was actually the glucometer wasn't actually pushed in the whole way on the dock site. So it basically, I think, died. The battery went dead type of thing. But they followed all their processes to the T, what they were supposed to do, all the things that were in place to prevent this from happening were done, but it was kind of like a simple error where it wasn't totally pushed in the whole way. So I just share that as an example of like you can get, whether it be the smart pumps, dispensing cabinets, the lab, when do they get the blood work in, when is it posted, when are the reads available? There's so much detail out there, and all of that is very helpful to finding out where the challenges are, where are the barriers, what went wrong in the event. Here's an example of a timeline. In code situations, you may not need to include the date. You're really honed in on the time. One of the other things I'll point out is just this talks about where that information came. Not necessary that you maybe put that into your timeline, but I will say sometimes in retrospect, then when you're having conversations down the road, it's very helpful to know where that information came from. Was it the code sheet? Was it that it was a timestamp? Where was it the electronic record? So those kinds of things are helpful sometimes to know where you pulled that information from. This is another example, again, of a timeline. And this was talking about labs and the critical lab being available. Again, was it phlebotomy? They did the draw, talking about how did the specimen actually get to the lab and looking at the pneumatic tube system. So again, as you put in these details, this might help you identify where the challenges are or where things broke down in the process. And now I'm going to turn interviewing. This will be turning over to Molly.
Thank you, Kelly. So now that you've had a chance to learn more about process maps and timelines, let's talk about planning the interview. So the interview process should be carefully planned, followed, and documented. Interview skills are foundational to gain a deeper understanding of what happened from the people involved. Effective skills take practice, and it is important to be cognizant of your approach. For example, in this slide, if you were the interviewer, I'm sure that you would not want to leave or project the same authoritative presence as this officer does, or for your interviewee to have the same disconcerting look on his or her face as this man. How effective is your interview going to be if your interviewee feels threatened or if the environment is punitive? So let's talk about some things to keep into consideration when planning and conducting an interview after an adverse event. So the timing of the interview. A good rule of thumb is to begin the interview process as soon as possible when memories and details are fresh. Also, the involved staff, witnesses, or other relevant parties may still be available to talk about what happened. I'm sure most of you know how difficult it can be to get in contact with staff or provider to discuss an event, especially if they are a part-time or a casual employee or work an off shift. So catch them when you can. And while it's important to begin the interview process as soon as possible, you want to ensure before you begin that you at least have an initial set of questions that you're ready to ask, being respectful of the interviewee's workload and/or personal time. This may allow you to get all the questions you need answered in one session. Additionally, it's important to talk to people when and where it is convenient for them. Perhaps it works better to meet virtually or talk over the phone rather than person. Provide several meeting time options for the interview and a rough estimate of the time that is needed. And if necessary, notify the staff member's immediate supervisor so that coverage can be arranged. And I know some facilities will actually pay their employees to come in for an interview if it's on an off shift as well. So that's another great incentive. So the location of the interview, you want to find a safe, private location in which the interviewee feels free to speak openly and will help them to relax. Maybe like on their own department or in a private office. Again, it may be necessary to conduct the interview via telephone or virtually. And at least one of my facilities, like many others, I'm sure, started doing all their interviews for their root cause analysis virtually during COVID. And they realized that that format was a lot more effective, that it seemed like people shared more in that format. So they've continued with their virtual interviews even after the pandemic. Provide a comfortable chair that doesn't face a window. You want the interviewee to be focused on you and your conversation, not what is going on outside the room. Also, depending on the culture, the interviewee may not feel comfortable if other staff, their supervisor or provider sees him or her talking to you behind closed doors. You want to respect their personal space, be considerate of chair arrangement. According to Psychology Today, the social space for casual and professional relationships is 4 to 10 feet apart one another, which to me, that seems pretty far apart. Avoid the appearance of summoning the interviewee to a deposition or administrative review, just like in our earlier slide, that is not what you should do. And remove any other extra distractions, like a computer, files, or paperwork. And again, this is so the focus can be on the interview. Some basic principles. Avoid intimidation. You want to explain the purpose of the interview. It is not meant to be used to assign blame. The goal is not only to discover information about what happened, but to identify system issues and behavioral choices that contributed to the event. This information, you need it to develop corrective action plans. So meet one-on-one if possible. It may be helpful, however, if you have the resources available to bring someone else along as a note taker. This allows the interviewer to concentrate on the conversation rather than on taking notes. If you do have a note taker, I would just make sure it's okay with the person that you're interviewing. Supervisors should also not be present during the interview if they're not involved in the investigation. And this is for several reasons. It can add stress to the interviewee in recounting the event. It could be perceived as intimidating, and staff are less likely to be fully transparent about the event and less likely to reveal true workflow patterns because they may fear punishment for not following protocol. If you can match your attire to the interviewee, that is helpful. I know when I worked in an office and had to wear business attire, if I was going to the floor, I would wear scrubs, and sometimes I even kept scrubs in my office so I could change. Use active listening by keeping an open body posture, using good eye contact, nodding appropriately to show that you were listening. Use repeat back or ask for clarification about what was said. And be aware of nonverbal cues, both your own cues and your interviewees. Be comfortable with silence. Your interviewee may need a few minutes to recall what happened, especially if it's been a while since the event, or they just might need time to process everything that's going on. Avoid interrupting or preparing your next question while they are speaking. Try to be patient, give them time to respond, and try not to prejudge. And we're going to talk a little bit more about that on our next slide. So bias. Humans have a natural tendency to form bias and establish a perceived reality without knowing the facts. There are two types of bias that I'm going to talk about today: anchoring and hindsight bias. Anchoring bias is relying too heavily on an initial piece of information. That initial piece becomes your anchor. As a result, it skews one's abilities to arrive at logical conclusions, make accurate estimates, or select suitable choices. Rather than viewing new information objectively, individuals with this type of bias might compare any new information they receive to their reference point or their anchor, which may result in a less accurate representation of the topic. So, for example, say you're hiring for a new position. When you're looking at the resumes, the first candidate's resume you review has their master's degree. Every subsequent candidate does not. Even though a master's degree may not be required for the position, you now believe that if a candidate does not have a master's degree, which is your anchor, they're not qualified. So in healthcare and the interview process, that would be relying on information learned maybe from that initial interviewee during your first interview and holding on to that as, the perceived cause of the event without digging any deeper. Hindsight bias is also known as Monday morning quarterbacking. This is a type of bias that causes people to convince themselves that a past event was predictable or inevitable. For example, it might cause us to think that we knew a particular nurse made a medication error because this nurse made one before. This is because our current knowledge allows us to easily reinterpret any previous errors as a sign of fault with the nurse. Humans have a tendency to have biases no matter their training, so how do we mitigate it? The first step is to be aware of it. It's human nature. We all have it. Also, try to avoid relying on a single source of information, pay attention to conflicting facts, and ask for a second opinion. And when you're thinking about a past event, just be aware that hindsight bias may influence your perception. So now let's talk about the interviewee. Who should you interview first after an event? Actually, the order of the event is not critical. However, it may be a good idea to request that staff do not discuss the event amongst themselves to promote the integrity and objectivity of the review process. This way, gossip or rumor mills are less likely to interfere with information, and witnesses will be less likely to be tampered with or intimidated. It is probably reasonable to talk with the individual or individuals that were directly involved in the event first. Depending on the nature of the event, however, interviews with those directly involved may be emotionally charged or challenging, keeping in mind there may be a second victim involved. Therefore, you may need to consider first interviewing coworkers that were not directly involved in the event, but are familiar with the process, followed by those that interact with the process, like the multidisciplinary team. This is where your process map might be helpful so that you can see how a process worked and what other departments are involved, and will give you a chance to see who else you might need to interview. Finally, you may also need to speak to some key stakeholders, including the patient. The information from your initial interviews will probably lead to more questions than answers and may identify others who might shed light on a breakdown in the system. And for example, I can remember when as a patient safety officer, I was looking into an event where a patient developed a pretty severe pressure injury. So, at first we interviewed the nursing staff and the patient care staff that were involved, but it was determined that, and this is something that, I learned, that the patient was ordered a specialty mattress on admission and they did not receive it. So we learned through our interviews that patient transport was responsible for retrieving the mattresses from the supply room when they were ordered. So then we had to go back and talk to, the transport team about that event. So again, look at your process maps and remember to include your multidisciplinary team. So interviewing patients and families, and this is something that, you might not be comfortable with, talking to the patient. That could be an uncomfortable situation sometimes. But if you think about it, patients are the only ones that are typically present throughout the entire course of an event. And sometimes their family may be as well. You want to interview them at a location that is acceptable for the patient and offer the family to be present for the interview. Again, you want them to be comfortable, just like if you were interviewing a staff member. Express that you are sorry that the event occurred. Act 79 of 2013, also known as the Benevolent Gesture Act, states any benevolent gesture, conduct, or statement that conveys a sense of apology, explanation, or compassion emanating from human impulses described in this law shall be inadmissible as an evidence of liability. And Shelley, if you could please post the link to this act in the chat, that would be appreciated. If you have any specific questions about the Benevolent Gesture Act, you may want to reach out to your risk management or legal counsel. So it's okay to say that you're sorry something happened. You also want to explain the purpose of the review is to identify system issues to prevent similar event from recurring and is not used to assign blame to anyone involved. That's really important to let the patients and their family know that. So how do you get started with the interview? First of all, you want to set the stage. The first few minutes of an encounter can establish the perception. You want to introduce yourself and your role. You want to explain the purpose, again, is to identify system issues. It's fact-finding, not fault-finding, and you're looking for opportunities for improvement. You want to make them feel comfortable. They probably won't be. Put yourself in their shoes. Sometimes, it can be a little bit, nerve-wracking to have to attend an interview, even if you didn't do anything wrong. It can automatically put you on the defensive. You want to state the anticipated length of the interview, offer breaks if they're over an hour, if it's going to be over an hour. Request permission for note-taking. However, don't let the note-taking interfere with the interview. Again, if you have a note-taker available, that would be helpful. Stress that the information from the interview is protected and confidential. And some special considerations, and you may need to wrap your legal counsel again in for this. But union representatives, if they're present, they cannot share any details of the discussion with anyone. So you want to stress that. And sometimes, patients or families may want their legal representation present as well during the interview. So what kind of questions should you ask? Well, interviews are a conversation with a purpose. So after you've taken a look at your initial process map and timeline, write down the questions that you have. You want to prepare your questions in advance, but be willing to go off script and ask additional questions as necessary. So I think sometimes this first question can be easy to forget to ask because you may be so focused on trying to find out what happened. However, it's really important to ask the interviewee how they are doing. How's their team doing? Do they need any resources? Is there a second victim involved? If so, are there any type of employee assistance or care for the caregiver programs available? And if you're not, so sure what a second victim is or would like to learn more about a second victim, You can check out our June 2023 Patient Safety Journal for a great article on second victims. And Shelley, if you could please post that in the chat as well, that would be appreciated. Then you want to start with some broad, open-ended questions about, tell me about what happened, followed by what normally happens. Was there any deviation? This is important to get a global perspective on what is going on, and it can also help to identify any type of drift. Next, find out what's supposed to happen. Many organizations will begin their investigation with right away, what does the procedure require? What was the policy? This can put employees on the defensive. We want to create an environment that is not threatening so we can learn what happened and what normally happens. It's not until you investigate that you might find an opportunity to prevent future occurrences. Ask the basics: who, what, when, where, why, and how, and try to ask questions chronologically. You should expect variations in the descriptions given by different staff when they talk about what happened, and don't forget to be aware of bias when you're doing your interviews. Some other questions and factors are to consider. Once you've completed your initial interviews, you may have identified some potential contributing factors. So examining these components of your organization's safety system can help to identify potential weaknesses in your system so you can zone in on the areas needed for improvement. If you would like to see some specific examples of interview questions that address these areas, please be sure to check out our website under Patient Safety Topics, Root Cause Analysis, Educational Tools. There you will find our guidance document for the root cause analysis investigation form, and also specific event type prompts for medication, lab, suicide, and now wrong site surgery events. And again, Shelley, if you could post that link in the chat, that would be great. So how to end the interview. A document, take notes, include the demographics, the name, job title, and date. Key factual points of the interview. Avoid assumptions or opinions about what is said or what you believe happened. Stay away from documenting subjective conclusions based on the interview. Follow-up questions that you may want to ask at the end. Make sure you write those down so you don't forget. Thank the interviewee at the conclusion of the process. Provide your contact information in case they have additional information that they remember. If you sense that they need emotional support, be aware of what resources are available to them. And consider, after an investigation is complete, soliciting their input or feedback on suggestions on how to improve the process. How can you make it more comfortable for them? So the next steps after the interviews, you want to go back and revise your process map and timelines as necessary. You wanted to start to identify some causes, start your action planning, and begin to generate ideas on how to prevent this from happening again, both immediate mitigation and long-term solutions. And just to wrap up, process mapping is used to create a visual representation of the process, to identify and mitigate errors and/or risks, to improve productivity, and to teach and train. Timelines just create a visual chronological order of events that occurred, and use interviewing to get a deeper understanding of what happened from the people involved. Be conscious in your approach and create a sense of comfort and transparency for your interviewees. And here are some references that we use for the presentation. So they're included in your packet. So you can take a look at those if you have some, want to learn more about anything that we talked about. So this concludes the slide presentation of our program.
Thank you, Molly. I do see one question that came in. What are some negative implications of bias?
Okay, so I would say, that bias sometimes seems to be more negative than positive, but it would be failure to being surprised by an event. So when you're not surprised by it, it prevents us from learning about it. So if we have a feeling that we knew it all along, it is unlikely that we will take the time to reflect and try to understand why our predictions at that time were wrong. So hindsight bias, will usually cause us to judge others unfairly for not have been able to foresee past events, and it can lead us to criticize other people's decisions in the past using information available to us at present. So
One other thing I can add, that I always I just like to share things that I've learned over my time of, being new in the field of patient safety and learning the investigation, things that I have learned over time. And I realize that many of us, myself included, I'm a nurse by background, many of us that are in these roles or in this presentation are coming from previous roles, maybe clinical, non-clinical, but it's hard to have 20 years 10, 15 years experience as a nurse, physician, respiratory therapist, medical assistant, whatever your role may be, and but to be honest with ourselves, that we tend to see things through those lenses. So I spent a lot of time being in the nurse role. If I don't check myself, I can sometimes look at things like a nurse. I'm in a new role now. When I was in a health system as a patient safety officer, I'm the person now that's facilitating this event investigation. I'm leading the RCA. I have to make sure that I take my own lenses off and look at things objectively and not just be narrow. And the other thing I learned and got better with over time is to recognize and intervene, like act as a facilitator when others were maybe making assumptions or using bias. I would, I had to kind of put the pause sometimes on like a nurse leader. Well, we know why that happened. We just need to re-educate everybody. No, we don't. We're not going to jump to an assumption. We're going to do this process and investigate the event and follow the steps like we do in every other. We're not going to make an assumption of why something happened. So those are just kind of things I like to share with folks of, recognizing maybe what's your own lenses that you have, and then deciding that you're going to be objective in this process and not have your own lenses on.
Thanks, Kathy. I know if anybody else wants to share, any participants on this webinar want to share some key things or helpful tips and tricks that you employ, please feel free to type them into the chat box. Certainly, if you have questions, please type those in. We have a few minutes remaining. I would like to just tag on to kind of what Kathy said, that I know when I left bedside care and went into patient safety, there were a lot of times that I would kind of think, well, this isn't how I did it. Well, this isn't how we do it, or this isn't what, wait. And it took me a while to step back and say, wait a minute, I'm not at the bedside anymore. I need to talk to the people that are still doing it, because it's hard to kind of come at it from an open perspective. But if you start doing those things where you're kind of, well, I didn't do it, or I did it this way, or man, things change quick in healthcare. The policies may not be the same, the processes, the supplies may not be what they used to be. So just making sure that we keep an open mind. And I really like what Molly said earlier too, about not using, kind of changing into scrubs. I know I worked with a colleague for years that had a suit and tie and a jacket, and that in going in to talk to staff members was it kind of shut down the conversation. So meeting staff where they are in their environment is a huge way to kind of open the door and get them talking.
And I want to when I see Jackie Adams left the comment just sort of on what I was saying, she's saying finds it difficult to remove the nursing hat, especially working in the same health system, healthcare system for 17 years. It's hard to do that. I agree. That's why I bring it up. I'm honest that it's something I wasn't great at, and I reflected and recognized that. So as I teach others, try to say, hey, look out for this. And it's not specific to nursing. I'm saying most of us in healthcare tend to come to a change in role after having been doing something else for a while, whether you've been a nurse on the floor for a while and now you work in quality safety, whether you've, whatever that may be. I'm just using that example. I would, again, encourage you, if you want to continue these conversations and be specific to your facility and what your current processes are, reach out to your advisor and be happy to, have a conversation and help you continue to build on these skills.
I want to thank everyone for joining us today. If you experience any issues accessing the evaluation and or certificate of continuing education, please feel free to direct any inquiries to Shelley Mikesell at shmikesell@pa.gov. And this concludes our webinar. Thank you, everyone.